I'm Vice President Medical Informaticist for MedSphere Systems Corporation, California-based company. I'm here with two of my counterparts, my Chief Medical Officer, Edmund Billings, and Robert Guajardo, the Senior Principal Architect for General Dynamics UK and US. Thanks for joining us. I just got my slides 30 seconds ago, so I'm not really sure why we're here, but I picked up the newspaper this morning. Hopefully this is one of the more controversial papers, but it says that the hospitals in the UK are bursting. Anyone disagree with that? Anyone disagree? I can tell you in the US they are as well. And as a veteran of the US military, we also have a pretty nice queue there, but it's much improved. So we're going to talk about a little bit about Vista this morning. We're going to talk about how Vista turned into another flavor of Vista, why OpenVista EPR in the UK, and then Rob's going to talk about the architecture, the flexibility. We'll talk a little bit about rapid implementation, lower total cost of ownership, which is very much a part of the total conversation, and then we'll open it up for questions. So hopefully there will be questions. Hopefully we get you thinking this morning. I love this slide because this is all about change, and if you've ever had something that you want, you've got to do something that you've never done. And my background, some of the things I'll talk about is really aviation. I'm not a physician. I've spent my whole life around healthcare, but physicians and pilots think a lot alike, so I'll throw some analogies in here. So who here has not heard of Vista? Is anyone not? Don't be shy. Okay, as a 13-year veteran, I had never heard of Vista prior to getting into medical informatics. So I didn't know prior to getting into the business. But we're going to show you a little bit about how Vista turns into something different. So the Veterans Health Administration is one of the largest, I call it an IDN, an integrated delivery network in the US. There's more than 1,700 hospitals. So very large. One of the largest hospitals is about 1,700 beds. Again, in the US, it's a big hospital. With more than 1,500 sites of care, and they see over 6 million patients with 75 million outpatient visits, with 152 hospitals, 965 outpatient clinics. So really a very robust system. By some measures, probably the largest health maintenance organization in the world, but that's my opinion. That may not be everyone's opinion. The Vista system is a full integrated EPR, okay? So if you've heard otherwise, we should talk now and later, but it's a full EPR. The Vista system was designed in a clinical setting for patient care. Not everybody can say that. This was a system designed for patients like me. The reality is the patients in the VA are actually a lot unhealthier. They're actually very sick patients. And to show how robust the product is, there are over 120 modules to date that work with the system, okay, in different applications. And the product is really about 80% out of the box, but there's a wealth of proven clinical functionality as it is. So if you hear people say that you have to build it from the ground up, they're lying to you. So just a sample of some of the things that the system does. If you want to look at this as a list, maybe 3 lists. Any clinicians in the group? Any clinicians? Okay, we have 1, 2, okay. So some of the things that you care about are listed here. In the next slide, we'll show some of the other things that the system can do. We don't have everything listed because we don't want to bore you, all right? It's a very, very, very robust system. So how does MedSphere and General Dynamics take a product from Vista, core Vista, to OpenVista? It's important to understand that when you look at Vista or OpenVista, you're not tied to a vendor. So who here has heard of vendor lock? Anyone here ever heard of vendor lock? I had it last week. Rob and I were working on slides, and I was trying to look at his slides, which were a different version. I had to call my IT department and pay for an upgrade to Microsoft in order to see his slides. It was very frustrating because we had already spent 13 hours that day on the slides. So that's vendor lock, okay? We leverage a national treasure, okay? So U.S. taxpayer dollars to date in excess of $8 billion on Vista. Another 5.8 earmarked for product improvements. So the money that we pay as U.S. taxpayers, you can take advantage of, right? It's a fully integrated EPR. I said that before, I'll say it probably 12 times. It's integrated for all clinical settings, okay? Hospitals, outpatient, clinics, and far out areas, okay? It's clinically broad and we use best practices. I know Dr. Shannon before me mentioned the book. Anyone here not read it? It's actually really good. I hate to read. It's actually really good. I recommend it, and I'll mention a couple things in my slides today. I mentioned earlier that we're in 1,400 sites, so Vista product is in 1,400 sites, 31 countries with over 200,000 daily users. Big numbers. Sometimes we get accused of having a product that isn't innovative, and I tell them that BCMA, does anyone know what BCMA is, barcode medication management? Anyone not know what that is? Once the drug is administered, you scan the barcode on the patient to close the loop. It's a very safe system. It was invented at the VA, okay? So lots of other vendors have taken that. We have other innovations that you'll see in the product. Real key takeaway with any EPR implementation, physician adoption is the key. If your doctors don't use it, doesn't matter what you paid for it, who made it, where it comes from, you're in big trouble. So this is a product built by physicians for patients, okay? And great engineers, of course. And to date, we haven't actually counted, but we figure more than 500,000 physicians have seen and or used Vista in the world. Here's a snapshot of what it could look like. There are hundreds and hundreds of variants. We have hospitals that have much prettier. We have hospitals that have less pretty. But depending on how important pretty is to you, it can be pretty. It can be as pretty as you want. But more importantly, it's what's behind the product. And Rob's going to talk a little bit about what's actually behind it. But again, this system will compete with any major system in the world. So now that you have sort of a background, why should we talk about OpenVista EPR in the UK? So I just mentioned earlier that it is internationally recognized EPR. It's in lots of countries. It's been localized in other countries. It can be localized here. The OpenVista product has a graphical user interface that is very physician-friendly, right? As an aviator, I don't necessarily care what's behind the avionics. I just want them to work. I want them to work. I don't want to have to reach down and flip a switch because that's bad. So doctors want the information at their fingertips that they can see and use and move on to the next patient, okay? So the user interface is actually very, very friendly in most cases. And the GUI interacts with the OpenVista core to provide a clinical user base, an experience that is very positive. All right, so again, the product was developed in part by physicians for patient care, so that it's been beat up over the years by lots and lots and lots of clinicians. It's a very reliable, scalable, and usable product. This is probably the most important slide that I could present because it really explains the history and the heritage of where we began. And you know, you could talk all day about Vista, but you have to talk about Indian Health Services. My chief government officer is in the back of the room. This is really his bailiwick, but this is a very large system in and of itself. So we take the code from the VA, integrate it into IHS, our PMS product, and MedSphere takes this code and brings it into OpenVista. So you're taking a very good system, a very good base system. You're adding more value, more usability, more functionality through the work that's done at IHS. And then we have our own in-house software company, if you will, software piece to make it more tailored to behavioral health facilities, to hospitals that want to have a pink screen and not an orange screen, to really, I hate the word customized, but it's almost If they want it customized, it'd be customized. It's very flexible, okay? I don't want to read to you, but the meaningful use piece, in the US, lots of money, I think 40 billion was the last number, probably more than that, was earmarked and is being spent to get software companies and hospitals and providers towards a set of goals. And I can tell you that with all of our clients, 100% of them reach their meaningful use goals. 100%. So getting there is not a small feat. And I think you may see similar parameters, similar goals come out over time in the UK, but the bottom line is about patient care. So you have to have a system that works for the docs to take care of the patients. All right? Any questions for right now? Okay. All right. I'm not an author. We have a question. Here, hold on, please.
Slides be available?
Yes. The slides will be available for a small fee. That's where I make my money. No, I'm just teasing. This book, again, I don't make money off the book. I didn't write it. I wasn't forced to read it. And I did bring 25 of them. They're just not here. So if you leave your business card, I can give you one. But the bottom line is that the Veterans Health Administration is the largest healthcare system in the U.S., okay? The largest. And they had a design goal to take care of patients. Imagine that. You're in healthcare and you actually want to take care of patients. And you want a product that's adopted, okay? Adopted. So it's got to be accepted by the clinicians, or else you're going to have anarchy. Anyone here trained on an EPR? I know we have 2 clinicians. Have you trained on an EPR, Doc? You have? How long was your course? Few hours, and he still doesn't know how to use it. A year and a half. A day and a half. So, okay. So a day and a half of training. A friend of mine's a neurosurgeon at Stanford. 12-hour typing course to use a nationally recognized EPR. 12-hour typing course. You know what 12 hours is to a neurosurgeon? They're not going to do it. They're not going to use it. They're going to get their residents to use the system, which is not what you want. The VA, 1 hour. 1 hour training, go to work. 65% of all MDs are trained on Vista, and the book talks about the Kaiser quality. This is more than just implementing an EPR. It's about improving outcomes. So the book talks about the outcomes and the system, how it's enabled to achieve those goals. Cost. Anyone care about the cost of systems? I'm sure the answer is yes to that. So the Congressional Budget Office estimated that the VA spend grew about 1.7% per enrollee. Okay, 1.7 sounds great, but relative to what? Relative to 29.4% over the same period for Medicare. So pretty profound cost-wise. I like to spend 60 seconds talking about, I'm originally from New York, so don't hold that against me. I didn't bring that up front, you would all left. But one of our flagship deployments is actually a hospital in Brooklyn, New York. Anyone here ever been to Brooklyn or New York City? Probably everybody. Getting a New Yorker to agree on the time of day, not happening. Weather, on anything, it's very difficult. 476 bed hospital, it's part of an IDN. They do about 90,000 ED visits per day. 700 physicians, 200 residents, you get the point, it's a big place. A lot of things happening there. CPOE adoption, 96% less than 30 days. You're probably thinking, what does that mean? They didn't use a whip. They didn't pay the doctors to use the system. They didn't get stock options. They're not paid by the hospital. This was a system change. They had volunteered up front to do this for the reasons that we talked about briefly. Huge numbers, the affordability, the money that they saved, and they continue to use the system. I wish we could show it today. It's beautiful looking. It's very usable. The docs love it. And we'll just, keep that as a snapshot if you ever want to see a cool story of a real implementation. Okay, Rob.
Thanks, Mike. So Mike has given us a pretty good background now on Vista, what it is, a little bit of the history, big application. I'm going to dig in a little bit. We've had some people come and visit the booth. We're just around the corner here, and ask some specific questions about Vista. So I'm going to talk a little bit about Vista as a fully integrated core EPR and a solid foundation or a solid platform for open source development. Vista has obviously been around for quite some time, and when I say it's a fully integrated core, meaning it has, Mike referenced 120 functional applications. So there's a lot of capability when you get Vista. All of the basic clinical applications are there, pharmacy, lab, radiology, etc. Many of the administrative functions for registration, all of these things that are necessary. And we list them here. What's important about that is that it basically provides a very good footprint for people who develop open source applications, whether it be a handheld device for helping to support registration, a portal for allowing patients to look through a web page and make their own appointments or to see what appointments they have. This core provides a huge canvas, if you will, for artists and developers to come and bring their value-added applications, whether these applications are open source or proprietary systems, they have those options. Why is Vista a good canvas for people who do open source development? I'll get into that a little bit later. Now, OpenVista will integrate today. Now let's talk about the trust. Trusts have today existing applications. OpenVista can integrate with all the applications that are there in place. Some of the trusts have investments there. They don't want to lose those investments. They have the option to integrate these things with Vista into the core and make the data that come through, for example, a PAS system. Having that data go in and feed into the core makes that data available to other systems, external systems. So essentially what we're saying here is everything can be integrated, all the bolt-ons, interoperability. So what's important about the interoperability? And I'm going to, more commercial and open source applications have been integrated with Vista than any other EPR system in the world. Why is that important to open source developers? The reason is, as an open source developer, if you spend your time and your money developing a component that integrates with an EPR system, and that EPR system disappears after a year or 2 or 3, what happens to your investment? You've lost it. Vista's been around for a long, long time, and because of that longevity and the canvas that it provides, many people have developed applications that integrate with Vista and are still using them today and modify them over time. So essentially what I'm telling you is that Vista is a very good ecosystem for open source development, whether it's, and commercial applications as well. When you look at the numerous systems Vista's benefited, VA invests a tremendous amount of money into the VA system. So it's continuously changing, improving as medicine changes, Vista changes. Much of that, and as Mike had said earlier, much of that investment, when he was showing the enhancements that come from Vista, get fed into systems like the Indian Health Service, and then Indian Health feeds back into Vista. Investment from the VA feeds into OpenVista. Well, and VA doesn't take those back, but it's kind of a one-way track. But those investments get leveraged. We talked about several organizations, including the Indian Health Service, the Department of Defense, commercial hospitals like the West Virginia, Lutheran Medical, as Mike had up on the screen. All of these people benefit from the investments that are made in Vista. So more about this continuing innovation. Because it's easy to modify Vista systems, it's also easy to integrate to them. There's been a number of interfaces, and I'm looking around and I can see some people. When we talk about open integration technologies for portal and mobile, and I see Rob Tweed sitting here. there's an excellent example using Rob's technology. The interfaces that can be exposed to Vista traditionally, or more common, are the read interfaces to be able to access the core data. Those are now being enhanced to do bidirectional integration using tools that Rob's developed. For example, technologies like Vista Link, technologies like Meadows. A number of interfaces now are allowing us to get access to the data that's embedded in the core. Why am I bringing this up here? The reason is that initially, applications that are attached to Vista for use, they were at one point in the early stages read-only applications. As time has moved on and people have been open source developers, like Rob, have made their investments on Vista, hang their hat on Vista, and found value come back to them from Vista. And now we've gone both ways. Now we're able to read data from the core and write data back to the core. And I believe there was a scheduling contest, companies like BT, Oroville Hospital, basically taking the core Vista application and showing what's possible. So again, a solid architectural foundation. The other part of this is that this system can scale from, unlike some of the proprietary, big, massive EPR systems, they're on mainframes. They're on pretty old operating systems. How these things can be ported and demonstrated is limited. Try and ask Cerner to bring one of their systems and install it here on the floor and show it to you. It's not going to happen. There's a lot of reasons for that. It's a very complex architecture. I have a Vista system sitting on a laptop in the booth around the corner. The difference is this Vista platform can scale from a laptop or even a netbook all the way up to an enterprise class rack system that is highly reliable. We're talking 99.95 reliability for a system. These systems go up, they stay up, and they work. They're perfect for a healthcare setting. That's the kind of reliability you need in a healthcare setting. We're standing in the open source Skunkworks area, so I thought it was good to mention. Here's some of the questions that I've been hearing about lately. What is Vista? What are the parts that make up the Vista system? How do I build one of these? This slide shows the pure open source stack, because we're standing in the open source area. And I'll go through. So from the hardware perspective, if you're going to use the pure open source stack, which is the lowest cost possible option, you have some restrictions on what kind of hardware you can run on, but this is commodity hardware. This can be virtualized in a VM. It can run on a laptop, for example. DB on Linux is essentially one of the primary versions of a free, you don't have to license it, operating system. Using DB on Linux, you can run the M database, the mumps database. There's a company called GTM, Fidelity GTM. No license for that system. And again, still no cost. And then from this point on, it would be Vista, or it could be OpenVista. And I start to show the levels where we can interface into the system. I've listed a few things. There's many. Node.js, EWD, Vista Link, Java, APIs, bidirectional access to the data and back out. RPC broker. Now this is something that many of the older technologies of interfaces leverage and use today to access data in a Vista system using RPCs. GDIT was awarded a contract by the VA just recently, in the last 30 days, for a project called Vista Evolution. Vista Evolution is essentially, as the title would hint at, the start and the beginning of opening Vista to web services, secure web services, to provide a new set of APIs to Java applications, to HTML applications, to applications that can be developed by the open source community. By exposing all RPCs that are existing in Vista today, it would provide a solid framework that would be easy to use and leverage for anybody. It essentially really opens this thing up. The Vista evolution, our first iteration, GDIT plans to be complete with this in the next 14 months and will expose over 400 APIs to web services. At the risk of beating a dead horse, in summary, and we've talked a lot about the interoperability and extensibility of Vista. Some takeaways, if you're going to take anything away from this, remember that more commercial and open source applications are integrated with Vista using more technologies than any other EPR system. That's a true statement. That's important for open source people who make their investment or their living using and developing open source applications. We also have enhanced, well, many of the systems that we interface with today. GDIT does work in the VA and Indian Health Service and the DoD. Using integration engines and standard HL7, which many healthcare applications use, we can get information and share information with existing PAS systems, existing laboratory systems, pharmacy systems, Baker cell devices, e-prescribing applications, what have you. These interfaces, and I want to talk a little bit about OpenVista. OpenVista built into the code and built into Vista, there are HL7 messages that are predefined to help simplify the integration. So you don't have to build these from scratch, they're available there predefined. OpenVista comes with 212 HL7 hooks, and they've been termed HL7 hooks because these are bidirectional interfaces that are available today when you use the product as your base. I can talk about Vista being localized, but I think Mike's talked about it. I'm going to turn it back to Mike, and we'll take questions at the end.
Okay, this is kind of my favorite part in that we like to talk about results. So when you talk to Edmund, myself, Bob, Rob, our CEO, it's all about results. It's not about the talk, it's not about the licensing, it's not about the sales pitch. Where are the results? So we'll talk about a system in West Virginia of 7 hospitals deployed in less than 22 months. 7 hospitals deployed in less than 22 months. Full adoption. All departments, 7 hospitals, less than 22 months. They didn't have to hire 120 full-time people to do it. The work was done by a very, very, very small and lean team. So let's talk about dollars. Do I need to say anything else? And if you're in the market like I am, and we tend to travel all over the world looking at different contracts and prices, that's actually low. 90 million is low, okay? So West Virginia has been a client of ours for 5 years. They just re-signed for another 5 years. The beautiful part of this is if they don't like us, if we don't earn our keep, if we don't produce the results, they can kick us out and go to another company that does open source deployments and service. And as the community grows, there will be more of them. So as there are more of them, you start working on economies of scale. That number could go down to 5 million, it could go down to 4 million. So in an era of declining reimbursement, not as big an issue here, but let's call a spade, there is not an endless supply of dollars anywhere. So in the US market, with accountable care, reimbursement is going down. Hospitals that used to work on a 2 or 3 or 4% margin, or 14, if they're in Los Angeles and they have movie stars, those margins are going to shrink. So IT budgets are going to shrink. Everybody's budget is going to shrink. But as I mentioned earlier, the patients are going to keep coming. They're going to keep coming. And they're going to fill the beds, and they're going to create more of a demand on the clinicians and the system. So you've got to have a scalable system that's affordable, okay? We typically say that out of the box, 80% functionality. 80%. There's a vendor here that wants to rule the world. They don't have 80% functionality out of the box, which means every percentage of functionality that they don't have, there's a fee. There's a fee. It costs more, okay? So the system can be tailored to the trusts. We have an outpost. It's a clinic in Nome, Alaska. It's a one clinician outpost. We have 1,666 bed hospitals. The system can work at either and everything in between. It can be tailored for small hospitals, big hospitals, outpatient, ambulatory, behavioral health. We already talked about the affordability of the system. Proven, I mean, this is just one deployment. The VA alone has thousands. Sustainability, there are no upfront costs, and we've proven that we have a lower total cost of ownership compared to almost every vendor, okay? And results driven. Again, this is a different, it's a different model. It's focused on results. When you focus on results, you get results. And when you get results, you get to stay. And I like to do a presentation. I won't do it today, but I talk about the sick care system in the U.S. It's really not a healthcare system. People are reimbursed for doing tests and for doing procedures. They're not reimbursed for results. We're reimbursed for results, okay? And you could certainly implement the same program here in the UK. We have 25 minutes for questions. We could do a lot of things. We could end it here, or we could have some questions for Edmund, for Bob, for myself, for Rob.